Yes, sir. Can you see now, sir? Okay, sir. Okay.
So, good evening, friends. We warmly welcome you for yet another postgraduate clinic. We have two important presentations one on oral cancer, other one is the cutaneous malignancy. We have Dr. Shriya Sujana from Sri Ramchandra Medical College going to present the first case. And we have Dr. Sana joining from Tirunelveli Medical College who will be presenting the second case. Today we have very eminent faculty joining us. Dr. Balaji Ramani is a faculty in MGM Cancer Hospital. We have uh, Dr. Akshay will be joining here. I think we have Sana also joined.
Yes,
Dr.
sir.
Akshay will be. Thank you, ma. Thank you. Please stay back. Dr. Sendil Kumar, Dr. Akshay, Dr. Rajkumar will be joining for the program. I request Dr. Rajiv Sahai sir, our senior colleague, senior faculty of the PG clinics, to conduct the program today. Before that, with the permission of the faculty, we share the important news that we have crossed 6,50,000 views of the postgraduate clinic. Thank you all for making this a possibility. Now, I request Shreya to share your PowerPoint and start your presentation. Good luck to you.
Thank you, sir.
Please share. Good luck to you, ma. Faculty, you will be having 1 hour per case, half an hour for the clinical part and half an hour for management part. Rajesh Sahai sir will guide you if there is any challenges. Sana, you'll be presenting second. Good luck to you.
Thank you, sir.
Yes.
Good evening to all the faculty, to all the prestigious faculty. This is Dr. Shriya. I'm a junior resident from Ramchandra Medical College, Chennai. Today I'm going to present about the squamous cell carcinoma of the scalp. A patient named Abdul, 71 from Chennai, Mama presented to our OPD. Chief complaints of swelling over the left side of the scalp for the past 3 years. History of presenting illness. Patient was apparently asymptomatic 3 years ago, after which he sustained an injury to the scalp following slip and fall at his residence, after which he developed an ulcer over the scalp, which was initially small in size, approximately 2 centimeters. Over the last 1 year, this progressed to a growth of the present size of around 5 centimeters and was associated with equal sensation for the last 1 month. There was no history of bleeding from the growth, no history of long-standing moles or recent increase in the size of the system, history of long-standing sun exposure present, history of other ulcerations over the rest of the scalp, body, no history of swellings in the neck, no history of cough, restlessness, hemoptysis, chest pain, bony pains. Past history, patient is a known case of systemic hypertension on regular medications, no history of consumption of any other medication, history of previous surgeries, history of any radiation. Personal history, family history.
Dr. Shreya, are you there?
Yes, sir.
Yeah, we've lost your slide.
Sir, now, so can you see it now, sir?
I
So
think you'll
can you
have
see
to.
the slides now, sir?
No, we can't. I think you'll have to start screen share again.
1 second. I am sharing my screen share.
Yes, please do.
So can you see it now, sir?
No, we can't. Just minimize your Zoom and then open your PowerPoint. Make it full screen and
It's
then go
open, sir,
to
now.
Zoom and then just minimize it.
Can you see it now, sir?
No, we can't. So just minimize your Zoom Go to open your PowerPoint on the
Yes, sir.
desktop and then
Yes, sir.
go to share. First, unshare the screen.
Okay, sir.
Yeah. No, just unshare first.
Yes, sir. I just did, sir.
Yeah. Open up your PowerPoint on your desktop and
Yes,
then
sir.
share the screen. Yeah.
Sir.
Yeah. That's it. Now make it full screen.
Yes.
Dr. Shriya, your slides are very. The font is very small. It's not being read. Very difficult to read. So can you make it Control plus and make it a bit larger?
Sir. So is this okay?
Okay, go on. We'll
Sir,
see
is
what
this
can be
okay?
done. No, the font, you've kept the font as I think 12 or 14, which is too small for a PowerPoint presentation.
Now, sir. Now
Make
let me
it
change
Control
the font.
the font to say 15 or 16.
It's on Keynote, sir, so I can't change the font now.
Okay, start, continue. Just non-battle with it now.
History. No history
Okay,
of
that's better.
ulcers to rest of the or elsewhere in the body, no history of swellings in the neck, no history of cough, breathlessness, or hemoptysis. Past history, patients and no case of systemic hypertension on regular medications, no history of consumption of any other medications, no history of previous surgeries or radiation exposure.
Again, we've lost your screen.
So did it stop again?
Yes, it has.
So is this okay?
Yeah, it's coming, but it's not loaded properly. It's very blurred. Is your network okay?
Yes.
So what you can do is you can turn down your video, you can shut your video down, and that's it. You have to do it again. We can't read anything.
Okay, so
Just stop sharing, reload it, and then start
yes.
sharing.
Yes.
Shreya, could you manage it? Okay, can you send your can you use another device, please? Yeah, that's better. Now No. You should open up your PowerPoint on your screen first. First, look, Dr. Shreya, open up the PowerPoint on your desktop first. Unshare it. Open up your PowerPoint. No, don't just keep it open. Are you using a phone or something? Dr. Shreya, can you hear me? Hello?
Yes, sir.
Can you hear me?
Yes, sir.
Just stop the screen share. Open up your PowerPoint on your desktop.
Yes, sir.
Make it full screen there.
Yes, sir.
Now go to your Zoom and start uh, share your desktop.
Okay, sir. Okay, sir. Sir, is this okay?
No, we can't see anything. Again, okay. Now show where is your PPT? Yeah, that's it. Okay, leave it like that now. Go on.
Patient was apparently sorry for the
No, make it
disturbance.
full screen.
Patient
Make
was
it full
apparently
screen.
asymptomatic.
Dr. Shreya, make it full screen. Yeah, we can't see anything.
Yes.
Yeah, go on.
Yes. Is this okay, sir?
Yeah, this is fine.
Patient was a patient named Abdul, 71-year-old
No.
male, hailing
Dr.
from
Shreya,
Chennai and a
Dr.
farmer by
Shreya,
occupation.
Dr. Shreya,
Yes.
we have gone through all
Yes,
this.
sir.
Just make it full screen first. Make it full screen. We have gone through this.
Is this okay, sir? This is full
Okay,
screen
go on.
on my iPad.
Yeah, now it's okay. That's fine. Go ahead. Go ahead.
Family history, there is no significant history in any other family members. 71 summary, a 71-year-old gentleman with an ulcer of proliferative growth over the left side of the scalp for the past 3 years, with a history of trauma and long-standing sun exposure. Provisional diagnosis, probably a chronic non-healing healing ulcer proliferative lesion of the scalp, probably of malignant etiology.
Okay, can we go to your first slide?
Yes, sir.
No, first slide of your history.
This is the first slide, sir.
This is general examination which you're getting now. Go to your.
No, sir. I went to the. I think it's slow.
Okay. Just yeah, that's it. So he's a farmer, and he has this.
Yes.
He sustained some injury.
Yes,
When
sir.
did he sustain this injury?
This was 3 years ago, sir.
So injury 3 years ago.
Yes, sir.
You've not written that, no? You just said injury and then to scalp following a slip at his residence, after which he developed an ulcer. After how many days did he develop an ulcer? Did he develop an
Sir,
ulcer there and then because of injury?
no, sir.
So what
Sir,
happened after injury?
sir, he
Did
said
he,
that after the injury it healed, but he recognized that there was an ulcer after that, after quite some time, like 2 to 3 months after that, he realized that there was an ulcer. It was non-healing, but he did not do anything for it.
hang
And
on,
he
hang
went.
on, hang on, Dr. Shreya. Dr. Shreya,
Yes, sir.
when he fell down, what injury
Yes,
did he
sir.
sustain? Was it a laceration? Was it a contusion? What was the injury which he
It was a
sustained?
laceration, sir. It was a laceration, sir.
So was it stitched?
No, sir, it was not.
He just left it like that. He didn't seek any medical attention then.
No, sir. He just said that he went to the clinic nearby, and then he just got dressings done, sir.
So after how long did that thing heal?
He said that he realized that there was an ulcer only after 3 months after he sustained the injury, sir.
So after sustaining injury and 3 months, what was the condition of that wound?
He thought it healed, sir. He said he didn't give too much attention to it after he stopped the dressings after 1 week. So he's also not sure.
So obviously, it must have healed then, isn't it?
Yes, sir. Yes, sir.
Right. And after 3 months, what
Dr.
happened?
Shriya, this is Dr.
Good evening, sir.
Sir, gone, sir. Hello.
Sir, good evening, sir. This is Dr.
Good
Balaji,
evening.
surgical oncologist from MGM Cancer Institute, Chennai. Good evening, sir.
Yes, sir.
I think what sir is trying to say here, Dr. Shriya, he's trying to point to the relevance of the history of trauma here. I'll just ask in a simple
Yes, sir.
way, do you think this particular history of trauma and injury is in any way related to the current ulceroproliferative growth that he has gotten in his scalp?
Yes, yes, sir. Trauma could be the etiology, sir. Trauma leading to an ulcer, chronic ulcer leading to the squamous cell carcinoma.
You think trauma is the cause of his current ulcerative proliferative growth? Do you think that is the
Can
cause
be,
here?
yes,
Just think
sir.
about it.
Can be if the trauma
Okay,
led
now,
to a non-healing ulcer.
yeah, so now the next question comes, like when you have trauma as a cause of, you think this is, you gave the final summary as it's likely to be a malignant neoplastic etiology that you have here, correct?
Yes, sir.
So generally, when you have a chronic ulcer going on to development of a malignancy, what do you call that ulcer?
Non-healing ulcer.
Is there a
sir.
particular name for that? No. Do you have a particular name for a malignancy developing from that ulcer?
Marjolin ulcer, sir.
Okay, great. So that is Marjolin's ulcer. But what are the common causes of Marjolin's ulcer? Where does a Marjolin's ulcer develop?
Chronic non-healing ulcers, where like trophic ulcers or venous ulcers, which are
Correct.
not
Chronic, yeah, trophic ulcers, venous
venous
ulcers, then
traumatic ulcers, repeated
yeah,
trauma to
trophic ulcers. Yeah, so repeated trauma. Do you think this patient has got repeated trauma here?
he did not give any history of repeated trauma, sir. But not sure.
No, see, you believe the patient or you don't believe him. Basically, you are
I
saying this is
believe-
related. That's why I
I
asked you the specific question. Do you think this is related to the initial trauma that the patient sustained? See, when you
prob-
say trauma as a cause of a malignant ulcer, what kind of trauma are you referring to?
repeated
You
trauma.
said
sir.
repeated trauma. That is the correct word, correct? So
Yes.
a patient sustaining a fall 3 years ago, and then it becomes, kind of like whatever he did, he applied some ointment, whatever dressing, and after that it healed. And after which an ulcer developed some, 3 weeks or 4 weeks later, or
Yes,
three
sir.
months later. That is the history here, right? So that is
Yes,
what sir
sir.
is trying to point out here. So the history is very relevant here in the sense that
Yes.
nobody gets a malignant ulcer by a single trauma or a road traffic accident or anything like that unless that becomes non-healing and that is
Ulcers.
subjected to repeated trauma. Okay, that
Yes.
is the point that sir is trying to make here. Okay, now please go on with the history.
Sir, do you want
So please continue with the things. I think she didn't understand what you were trying to get to. This is the kind of scenario in the exam that you shouldn't miss in the exam. That is what sir was trying to allude to.
Okay, yes. General examination, patient was examined in a
No,
well-lit
hang on,
room after
Dr. Shriya.
taking consent.
Dr. Shriya. Dr. Shriya,
Yes,
we are
sir.
not
Hang
done
on,
with
it's
your
not
Yes,
yet
sir.
over. It's still in history.
You're not done with history.
Yes, sir.
Just go back to your history slide. Okay. So this male, he fell down, had sustained injury and after 3 months, he developed an ulcer. And probably the thing would not have healed completely.
Yes, sir.
This is on his scalp. Does he
Yes,
have
sir.
hair on his scalp?
Where there was
These are
lesion,
combing.
sir.
Did that thing bleed on combing?
I'm sorry, sir, I didn't understand.
Did the lesion bleed, get repeated trauma when he combed his hair? Or is
Yes,
he
sir.
bald?
Yes, sir, maybe.
No, not maybe. Did you ask him whether he's getting repeated trauma or not?
Oh, he didn't give any history of bleeding, sir. They repeated
No, did
trauma.
you ask him? He
No,
might not give.
sir.
Did you ask him? Did you
I
ask
didn't
him?
ask him. No, sir, I didn't ask him any history.
So you're supposed to ask. Look,
Yes.
Dr. Shreya, you're
Yes, sir.
making it a squamous cell carcinoma, right?
Yes. Yes.
Because of a chronic ulcer,
Yes, sir.
right? Like Sir said, there has to be some sort of offending, precipitating factor which will turn a ulcer into malignancy. You get me?
Yes, sir.
Yeah.
Yes.
So that is a lacuna in your history. Okay. Now, what else
Yes.
did you ask in history?
Yeah, usually, how much time does it take to become a marginal ulcer from a chronic injury? How much time does it take that? Do you think within 3 years somebody has got a trauma and he can develop ulcer or the malignant ulcer over that in 3 years' time?
No, sir.
It's a very long history, you know. And whenever
Yes.
there is trauma is there, if there is underlying osteomyelitis is there, then that can precipitate as a malignant ulcer जो है, or the marginal ulcer. Okay, not a simple trauma to the skin will cause that. Okay.
Yes.
So you have to think really whether this trauma is a cause for that or not, or it's something else.
Okay.
It may not be malignant.
Doctor, what both of them are trying to allude to is a single history of trauma will not lead to an ulcer. And second thing is the duration of a chronic ulcer. See, even a 2-3 year ulcer, even if it is non-healing, is unlikely to develop into a marginal ulcer. As sir said, it is likely to take at least 15-20 years on an average. Okay, so that is why you get it in more chronic ulcers like burns, like osteomyelitis and things like that, where it happens over a long time. Okay, not in such a short time as 3 years. So now, what do you think is actually happened here? If you think that that is not the reason for, it is unlikely from what you're saying, 3 years, one history of trauma, nothing major after that. It is unlikely that that is the cause of the squamous cell carcinoma, which has apparently happened now. So what do you think has actually happened here? What is the relation between the history of fall, the initial wound, and the current, status that he has got?
Probably didn't heal and he was having repeated trauma to that site, sir, again and again. That's why.
Anything else? Anything else?
Sun exposure.
What is pyogenic granuloma?
Neovascular growth, sir. Pyogenic granuloma. After repeated trauma, neovascularization occurs there and a growth.
Because you've written there was no history of bleeding or discharge from the growth. Do you think that a squamous cell carcinoma of a 5 centimeter size would not bleed? Would it? Do
Yes.
malignant ulcers bleed?
Yes, sir. Hello.
Okay,
Sir,
let's go to your next.
on
Yeah.
long scan, the tumor becomes too huge, then it may bleed, sir. But in general, no, they won't bleed.
Even if it is a small malignant ulcer, it is
Yes.
most likely to bleed. Okay. At least there'll be some discharge. If there's no bleeding or discharge from the growth, that means it's just a growth. It's not, you're saying it's a growth. And then you're saying it's
Yes,
an
sir.
ulcer. So what is it? Is it a growth or an ulcer? Or is it ulcer proliferative condition?
It was like an ulcer proliferative condition, sir.
So there's an ulcer there, isn't it?
Yes, sir. There was crack in it. Yes, sir.
So ulcer means there is a breach of epithelium.
Yes, sir.
So if the epithelium is breached, some amount of discharge will be there. Okay. Let's go to your next slide.
Now, doctor, you mentioned repeatedly that there is chronic history of sun exposure in this patient.
Yes,
Correct?
sir.
He's a farmer, he has got sun exposure, all these are the factors that you mentioned. Now let's
Yes.
assume for argument's sake that that is the cause of this particular ulcer and the trauma
Yes.
just draws attention to it. Many patients, whenever you have a breast cancer, for example, they'll say, I had a child hit my breast, and after that the trauma draws their attention to the ulcer or swelling rather than being the cause of it. Correct?
Yes, sir.
And in a similar way, here, if you think that sunlight is the cause of this ulcer, what would have been the pre-existing condition here?
Solar keratosis, sir.
Perfect. So that was the answer I was looking for. Yes. So what is the solar keratosis?
Chronic. It is a pre-malignant condition where like the patient's skin will be really sensitive to the sun-exposed areas, and they'll develop scaly reddish lesions, which will further develop into carcinoma.
Okay. So the relevance of this question is, in this particular patient, did you ask about any history of this kind of scaly, itchy lesions that could have been present previously and later developed into an ulcer? That is why I asked this question. Because he's a farmer,
Yes.
because he had this ulcer, do you think, I mean, isn't it relevant that you should have asked this history?
Yes, sir.
Okay. Fine. Go on with your presentation, doctor.
Okay, no history of cough, breathlessness. This is because of secondaries, right? Metastasis.
Second. Yes. Yes, sir.
So squamous cell, where does it metastasize usually?
So,
Squamous cell carcinomas, how do they metastasize?
locally aggressive, sir. Otherwise, if they have to metastasize, they can metastasize to lymph nodes. And if there is a hematogenous spread, the first metastasis would be to the lungs, then to the bones and brains, bones in the skull.
So it is lymph nodes which is important, isn't it?
Yes, sir.
And you said that the no lymph nodes. So you think it can go to the be hematogenous without going to the lymph nodes?
Yes.
Okay. Next slide, please. Systemic hypertension. Okay. Does not work. No. Okay. So in this, just by your history, how can you come to a diagnosis of probably malignant?
So I thought like an ulcer which was long standing for more than 3 years with repeated sun exposure leading to an ulcer or proliferative growth would probably mean a malignant lesion.
Okay, what could be your differential then?
Squamous cell carcinoma or basal cell carcinoma both.
That's it. Only carcinoma. You will not think of any benign conditions. Would you or would you not?
Yes.
So, like Sir said, it could be a chronic, it could be osteomyelitis leading to a chronic ulcer,
Yes.
right?
Yes.
It could be. Right. So, please.
What is the Cox peculiar tumor?
Sir?
What is Cox peculiar tumor? Can you have the sebaceous cyst over the scalp?
Yes, sir. Yes, sir.
So can that present as a ulceroproliferative type of the lesion?
Yes, sir.
I think that should be one of your differential diagnosis. What is the Pott's Puffy tumor? If the osteomyelitis is there, it can present like a tumor and then it may ulcerate. And if the patient has got the tuberculosis, then more so you have to think about that. Because all these are your differential diagnoses. You cannot directly jump in this patient that you are dealing with a case of a squamous cell carcinoma. No?
Yes.
Yeah.
Good evening, Rajiv sir. Good evening, Balaji sir.
Good evening, sir. Good evening, sir.
Yeah, this is Dr. Vijay, surgical oncologist from Trichy, sir.
Yes.
Good evening,
Hello,
sir.
Vijay.
Hi, sir. I have been asked to attend on behalf of Dr. Sendil from Trichy. He is held up in a case. So may I pitch in with some questions?
Yeah,
Yes,
please.
please, sir. All yours.
Yeah, Dr. Shriya.
Yes, sir. Good evening, sir.
Yeah, good evening. Yeah. So can you give me a definition of a non-healing ulcer? So when do you say it's a non-healing ulcer?
An ulcer which doesn't heal for more than 3 weeks.
Okay, good. So some textbooks say 3 weeks, some definitions say 2 weeks. Both are accepted. So you had said this is a probably malignant etiology according to you. So can you substantiate that malignancy as an etiology from your history and physical examination? Just the points in favor of malignancy.
Points in favor would be a long-standing ulcer for like 3 years, with adequate sun exposure, with trauma, and an ulcer proliferative growth.
Okay, can you start with the age? Is it the common age for a malignancy?
Yes, sir. A 70-year-old male patient, farmer by occupation, repeated sun exposures, trauma with an ulcer for a long-standing time.
3 years swelling, do you think it was more favorable of benign or a malignant etiology? For 3 years,
Benign.
it's been there, right?
Yes, sir.
So
Benign.
that is something which you cannot call it in favor of malignancy. What you
Yes,
can
sir.
call it in favor of malignancy is probably the history of rapid increase in size or characteristics, a recent change in the character or a recent rapid increase in size. All right. And when you asked about the long-standing sun exposure, you also have to ask whether it was a chronic type of sun exposure or an intermittent, brief episodes of exposure of higher intensity. Because that is something which can differentiate, between basal cell carcinoma and the squamous cell carcinoma. So which one do you think is risk factor for squamous cell carcinoma, the chronic sun exposure or the intermittent exposure?
Intermittent, sir.
No, it's actually the chronic sun exposure. So this is what you'll be commonly asked in the exam. Like when you are giving a diagnosis of malignancy, they'll ask you what are the points in favor of malignancy. You have to start with the age, duration, any recent
Yes.
rapid increase in size or change in character, and the other risk factors which you have told. If it doesn't fit into the etiology which you have suggested, do not try to fit it in. You can justify always, and you can say these are fitting in, these are not fitting in. Okay,
Okay, sir.
fine.
So does
Okay,
this
let's go to
patient
your.
actually give a history of recent change in size of the ulcer? See, because even a chronic ulcer, Marjolin ulcer, for a long time it will be a simple ulcer and not a simple ulcer. For a long time it will remain static or very slowly changing, and suddenly there will be a proliferation and they just will start bleeding, have a discharge and things like that. So did you ask for any specific history like that?
Yes, sir. I did ask for sudden increase in size, but he told that it has been slowly increasing in size for the past 1 year, sir. Before that, it was like an ulcerative lesion. Then it started like becoming like a growth, and for the past 1 year, it has slowly increased and became to the current size.
Okay. So would you offer a benign diagnosis considering this particular history? I mean, I know that you have not yet gotten into examination. So as of now, you have a long-standing ulcer there. 3 years duration, no sudden changes. And as far as the history goes, there is no history of bleeding. There is no history of discharge. Not much pain either. Nothing is there. So can we think of it as, let's say, is there an osteomyelitis? He had an injury, non-healing. Maybe he had a small chip fracture or something. Could it be an osteomyelitis?
Yes, sir.
Do you think that's likely?
If we take like the short duration of history, yes, sir, maybe.
Not short. This is a long. See, again, whenever you're answering in exams, doctor, answer
Yes.
pertaining to your case. So here I'm asking, do you think it is likely that it is chronic osteomyelitis of the
Yes, sir.
probably the parietal bone? I've not yet seen the patient or the clinical finding, but of the parietal bone, do you think it's likely?
Yes, sir.
See, doctor, again, I'll tell you one thing. In your exam, the examiner will often ask questions for which the answer is likely to be negative as well. So they just want to test you on how sure you are with regard to your findings and your history and everything. So the answer to this question is, it is highly unlikely, because scalp is one area which will heal very well even if you don't do anything. It's that kind of thing. Non-healing ulcers in the scalp are very rare unless there is an infection or some kind of long-standing tuberculosis. Very rarely. I've never seen one actually. Other areas it will tend to happen. In this particular area, it's highly unlikely. So you can give a differential if you are pushed for it, but then think of it as a relatively rare thing. It is not very common. Okay, doctor, go on. So the point is, don't just change your answer immediately when you're asked a question by any examiner. Remember that your answer could be right and they are just testing on whether you are, getting the reasoning right.
Yes, sir.
Yeah, go ahead.
General
Let's look at
examination, patient was.
Sorry.
Sir?
Yeah, go on.
General examination, patient was examined in a well-lit room after taking consent. Patient was conscious, oriented to time, place, and person, thin-built and moderately nourished, with a height of 170 centimeters and weight of 54 kg, with a BMI of 90 and ECG score of 1. Heart rate of 88, normal rate, rhythm, and character. BP of 130/80, measured on the left hand sitting position. No pallor, icterus, sinus clubbing, pedal edema, or generalized lymphadenopathy. Local examination, inspection, and ulceroproliferative growth of size 5 × 4 centimeters occupying the frontoparietal region more towards the left side, 1 centimeter from the midline. Hemispherical in shape, irregular surfaces with crusts and areas of hyperpigmentation and granulation tissue with areas of everted edges, irregular margins. Surrounding skin appears normal with no dilated veins, scars, sinuses, ulcers, or satellite nodules. Palpation, inspectory findings are confirmed. The swelling is firm in consistency, mobile in all directions, does not appear to be fixed to the underlying bone. No warmth or tenderness on or around the growth. No bleed on touch. On neck examination, inspection, no visible swellings in the neck or supraclavicular fullness. Palpation, no palpable cervical nodes. Should I go ahead, sir?
Yes, please.
Systemic
Go on.
examination, cardiovascular system. S1, S2 heard, no added sounds. Respiratory system, bilateral vesicular breath sounds heard, no added sounds. For abdomen, soft, non-tender, no palpable lumps or organomegaly. Summary, a 71-year-old male presented with complaints of ulceroproliferative growth over the scalp for the past 3 years. Initially started as an ulcer of approximately 2 centimeters size, gradually progressed to an ulceroproliferative growth of size 5 × 4 centimeters associated with itching and prolonged sun exposure. Hemispherical in shape with irregular surfaces with crust, hyperpigmented areas, and everted edges, and irregular margins, the swelling is firm in consistency and mobile in all directions. Provisional diagnosis: a malignant ulceroproliferative lesion over the scalp, probably squamous cell carcinoma.
Doctor, can you just go back to the examination slide a minute?
Yes.
Okay, now, let's say, suppose you find some lymph nodes in the neck. For this particular patient, where would you expect the lymph nodes to be present?
Cervical nodes.
Yeah, I mean, obviously cervical. So what are the groups of cervical lymph nodes?
Level 2, 3, and 4, sir. Which one?
Is there any particular group that might happen much before the level 2, 3, 4?
Subman.
So when you say
Post-articular
level
and
2, 3, 4, since you have told me about level 2, 3, 4, can you just tell me the anatomical extent of level 2, 3, 4?
Digastric upper, middle, and lower, sir, it's divided. Just anterior to
Digastric.
the sternocleidomastoid. Upper jugular, middle, and lower, sir.
No, is it digastric or is it jugular?
Jugular, sir.
Okay, so jugular, upper, middle, and lower jugular. Fine. So you said anterior to the sternomastoid.
Yes, sir. Posterior will be posterior triangle, sir. Post-auricular.
No. I'm asking you about level 2, 3, 4, ma. Can you tell me the anatomical boundaries of level 2, 3, 4?
Angle of the mandible anterior to the sternocleidomastoid and clavicle, sir, inferiorly.
So you're talking about anterior to sternomastoid. Is it anterior to anterior border of sternomastoid or anterior to the posterior border of sternomastoid?
Anterior to anterior borders.
Anterior to the anterior border of sternomastoid.
Yes.
Now, in general, whenever you're classifying or giving landmarks for any boundaries, what are the landmarks you will use?
Bony landmarks.
Okay, so sternomastoid, what is it?
Angle of muscle, sir.
Okay, so angle of mandible is one boundary you said, clavicle is another you said. Okay, that is two boundaries. That will just give you one region. So 2, 3, 4, how do you differentiate then?
By bony landmarks, sir.
Yeah, which bony landmarks, doctor? That is what I'm asking.
Mass.
Sorry?
Not sure. Not sure, sir.
You're not sure. Okay. Now, I'll compliment you on one thing. First, in telling very clearly that you don't know the answer to this question. Now, I have no other option but to pass on to another question and ask you this. This is also very important in the examination. Okay. That compliments you on that, because saying that I don't know requires courage. That is important. On the other hand, though, when you mention level 2, 3, 4, the next logical question is for the examiner to ask you what is level 2, 3, 4. So in general, to whoever is listening in the audience and to you as well, whenever you're presenting anything in the examination, be prepared
Yes.
to answer the question that follows. See, when you tell somebody, then the next question will be based on whatever you're told. That information will provide the subsequent question basically. So in a way, you can lead the examiners towards areas where you know a little bit about things. So if you say the levels of neck, if you know the levels of neck, then you're going to get, suppose you know level 2, 3, 4, the boundaries perfectly, and you say level 2, 3, 4, then perfectly you will be answering one question at your level, and people will be happy and they will award you more marks, or it will be positive for you in the examination. This is one thing you need to remember. And as a corollary to that, I will also say that when you do not know the answer or you're not sure of something, do not mention that in the examination. Because if you do, then they will ask you questions and you will end up not answering.
Yes.
Okay. Right. So you need to read up on that. I'm not sure whether it's the right forum to tell you the anatomy of everything. So in this particular question, the point that I wanted to highlight was whenever you have any frontoparietal swelling that is going to be there, frontal parietal ultraproliferative growth, is there any other node that can happen before it spreads to the neck nodes, to the cervical group of lymph nodes? Just think logically, you will get the answer.
Post-auricular.
The post-auricular or even before that, this is frontoparietal, right? You have the preauricular or the parotid nodes which are going to be there, which is going to be the training area is going to be this, right?
Preauricular, yes.
So that is going to be one thing which is very apparent here. You may get a preauricular or a parotid node in this scenario even before you get a neck node. Usually it goes there and then goes on to the level 2 of lymph nodes and probably further down as well. Okay, why I asked that was there was no mention of the preauricular region in your findings. That is why I asked that question specifically. Okay, now you also mentioned that it is mobile in all directions.
Yes, sir. It's free from the underlying bone, sir. I was
Yeah,
able to
see,
move it
you mentioned
horizontally.
that, so that will be actually a better term to you. See, the mobile in all directions is a term that you will generally associate with the freely mobile swelling like a fibroadenoma. You can say that the mobility is not restricted
Yes.
in any plane. It is not attached to the underlying structures. That way you can put it. The conclusion was right, but mobility wise, I'll say it's probably better to say it is arising from the skin and it is not fixed to any of the surrounding structures, the bone, basically. Okay, the mobility is not restricted. You better.
Normally we know that the cervical lymph node, there are 7 groups of lymph nodes are there, isn't? Is that correct?
Yes, sir.
Yeah.
Yes, sir.
Yeah, but there can be level 8, there can be level 9, and there can be level 10 also. Level
Yes,
8
sir.
is parotid. Level 9 is buccofacial. And level 10 is occipital. Okay. So this swelling which is there, though it is slightly anterior, but if it is slightly posterior is there, it can go to the occipital nodes also. Okay, so apart from the parotid nodes, buccofacial nodes, and also to the occipital nodes. Okay. Yeah. So based on your clinical, what is your diagnosis now?
I think it's squamous cell carcinoma of the scalp, sir.
Dr. Shia, so in
Yes, sir.
palpation, do you think mentioning the induration is important? Mentioning about the induration?
Yes, sir. I mentioned. Yes,
Have
sir.
you
I
mentioned
checked
that?
for it, sir. Sorry. Forgot about it. Yes, sir.
So not only you have to mention about the induration, you should also comment on whether the
Yes, sir.
induration is extending to the surrounding skin also. Am I right?
Okay, sir. Yes, sir.
So why do you think that is important? Let's say this patient has induration extending to the surrounding skin up to 1 centimeter from the lesion edge.
Spread,
So,
sir. Spread.
yeah, let's say patient is having induration of the surrounding skin up to 1 centimeter from the lesion edge. So why do you think this is important?
When we are exercising, we'll take beyond that 1 centimeter, and for clearance, we'll take another 5 mm, sir, 5 to 6 mm.
Yeah, so yeah, you're right. So you'll have to put it in a better way. So the margins, you take it from the lesion edge or from the induration edge?
From the induration edge, sir.
Yeah, so that's the point I wanted to make. Good. So you have to always mention about that, and that is one of the hallmarks for characterizing this ulcer as a malignant ulcer. So there would be induration, and that induration you'll have to mention how much it has gone beyond the lesion, because it has implications for the treatment purpose also. And as Sir said, always remember, it's not only the cervical nodes. You have to always keep in mind the anteriorly the preauricular,
Yeah.
parotid, facial, and buccal nodes. Posteriorly, the postauricular and occipital nodes. Yes. Okay, go ahead.
So would you, you said this is an ulceroproliferative growth, doctor, correct?
Yes, sir. Yes, sir.
From the way I look at it, okay, can you just describe that ulcer component to me?
Actually, there was a breach in the epithelium, sir, when it was growing, so I couldn't mention it as just a proliferative lesion there. Like, I'll breach in the epithelium, so I just mentioned it as an ulcerative lesion also, sir.
This looks more like a kind of like a tumor with ulcer on top of it rather than an ulceroproliferative lesion, if I may say so. even the description as hemispherical, all that is, it's not characteristically what I would say. I mean, I'm not able to see very clearly, but from what I can make out, it looks more like a proliferative lesion rather than ulceration. Forgive me, I'm not able to see it very clearly. It seems mere proliferative with a little bit of ulceration at the summit of the swelling. Am I right? I'm not very sure of that, but that's how it looks to me on the image.
It looks like a warty type of the tumor, isn't it? Like the wart, if a big wart is there. Something like that, yeah.
Now, why is this question relevant? In the sense that, if it were more of an ulceroproliferative growth, okay, in a classical squamous cell carcinoma scenario, what would be the edge of the ulcer?
Everted, sir.
So do you think this lesion fits into that kind of category?
On one side, I could see the everted edges, sir, but otherwise, no, sir.
Okay, because to me it looks like what sir said now, like more like a warty thing, or like a proliferative growth which has ulcerated later on, So does it open up the differential to something else? That is what I want to get here, Here again, the history becomes important, because is it a long-standing ulcer, or is it just a growth or a bump which was there kind of thing, which later on ulcerated? Because as sir told already, it is very unusual for an ulcerated lesion of 3 years not to have any discharge, any bleeding. Yes. Almost impossible to have it like that. This one can have such kind of picture, because it's more like a tumor which has then later on ulcerated at the summit where it has given way.
Actually, Dr. Shriya, you would not
Yes,
be
sir.
wrong if you could call this as a benign growth also, because all
Correct.
the history and examination which you have enumerated so far, it perfectly fits into a benign lesion. 3 years history, slowly progressing, no obvious risk factors, and in examination, it doesn't look everted as Balaji sir said. It looks like a well-defined, lesion, and there's no induration, and there's no bleeding on touch. So you should keep your differentials open, even if you have seen the biopsy report or you know that the histopathology is different. You should always go by the history and clinical examination. Based on that, you can go and give your diagnosis. It may be right, it may not be right, or it can turn out to be something after the investigations. But what the examiner would look at is how you are, formulating your differential diagnosis based on just the physical history and physical examination. That's what you're being tested for. Okay.
Doctor, can you just tell me, in this tumor, in the skin of the tumor, what percentage is actually covered by skin and what percentage is ulcerated?
So maybe 30% ulceration, but otherwise most of it is covered by skin, but it has cracks, sir. Like
Okay,
scaly.
so no, the point I'm trying to ask you is it a subcutaneous swelling or is it a cutaneous swelling?
It looks like cutaneous swelling only, sir.
No, because a cutaneous swelling having 70% skin cover is unlikely. You get that even your description doesn't match a cutaneous swelling. It looks more like a subcutaneous swelling, which has actually ulcerated at the summit. That's what it looked like to me. That is why I'm asking again, because the picture is not very clear. I mean, I think my connection is bad or something, but it looks more like a subcutaneous swelling which is ulcerated.
Yeah, do you know what are the benign tumors of the skin? What are the various benign tumors of the skin?
Benign nevus, benign basal nevus. Papillomas.
Yes.
Benign papillomas.
Yes. What is another
Pyogenic
one?
granulomas.
Huh?
What?
Dermatofibroma, keratoacanthoma, keratosis. All these are the benign tumors of the skin. Huh?
See, now, given the discrepancy in the history and the clinical findings I won't say discrepancy, actually, as Dr. Vijay said, it more fits in with a kind of long-standing benign swelling rather than clearly indicating a malignancy here. And since it is almost 70% covered by skin, is the skin pinchable?
No, sir.
You are sure regarding that?
It's not pinchable. Yes, sir. Very sure, sir.
Anywhere it is not pinchable?
No, sir.
Okay. Could you offer any other differential here, doctor, either in terms of a benign or a malignant swelling? Other than squamous cell carcinoma, one suggestion which actually among the differentials that sir mentioned now could be a possibility here.
Or what, sir?
Sorry?
What, sir?
Not really. An intermediate grade tumor, to give you a clue.
I can't.
Could it be a dermatofibroma or a DFSP? Would you care to put it as a differential, doctor? You know what is DFSP?
Sir?
Do you know what is DFSP?
I'm not sure, sir.
Okay, DFSP stands for dermatofibrosarcoma protuberans, which may actually present. It's uncommon in the scalp, but it can rarely happen. But this presentation of more like a subcutaneous thing and skin not pinchable is one factor against it, but then it's more like a dermal sarcoma. So that could be one differential here. So remember, as Dr. Vijay said, no, just because you know the biopsy report and that is common, unless it fits in characteristically with your diagnosis, don't offer that as your first this one. You can even say that I would like to give a differential.
Yes.
Because this kind of presentation, I wouldn't really classically call it as a squamous cell carcinoma of the scalp. It is not, it doesn't look like that on first impression. You can always say, I will give a differential and I would like to do a biopsy. There's no harm in saying that. Okay, doctor, go ahead. What would you like to do for this patient?
Sir, first of all, I would like to take an edge-wedge biopsy and an X-ray of the skull to see if it's because it's long-standing, if it's eroded the skull, and edge-wedge biopsy to know what is the pathology of that lesion, sir. And if it turns out to be squamous cell carcinoma, I would like to do a USG neck to rule out secondaries like nodes, sir. And if there are nodes and if I need to do a metastatic workup, I would do a chest X-ray. If the nodes are present in USG of the neck, then I would go ahead with a CT of the chest, sir, or a bed CT.
See, doctor, you're giving a very wide spectrum from, doing an X-ray of the scalp to ultrasound of the neck and then going on to CT, chest and PET CT.
Sir, I would do an edge-wedge biopsy of that
The
lesion
biopsy,
first,
I
sir.
agree. Why an edge-wedge biopsy?
Sir, differentiated from the normal skin, sir.
Okay, so you want the normal tissue included for the pathologist to compare with. Okay,
Yes,
right. So
sir.
that is an edge-wedge biopsy. So here, can you actually do an edge-wedge biopsy?
No, sir.
So then why do you say edge-wedge
sir.
biopsy? because the edge does not extend completely in the tumor, right?
Yes, sir. Excision biopsy.
You want to do an excision?
Yes, sir. Excision or shaving. Shave biopsy or excision biopsy.
See, doctor, you can say I will do a wedge biopsy. It need not be an edge wedge biopsy, or you can say I will do it from the proliferative part. That edge is very well defined. From that part, I will do it. It's still an edge wedge biopsy. This is what I meant by saying that don't go back on your answer immediately when somebody asks you a question. Okay, here the edge is pretty well defined here. So you can take take a biopsy from the edge of the tumor, and a bit of the normal tissue also you can take to differentiate between the two. It is possible even in other things, not just in an ulcer. Okay, so you can do the so-called edge wedge biopsy even here as well. No need to do a shave biopsy. It's unlikely you will do a shave biopsy in this kind of scenario. Where will you do a shave biopsy?
Normal squamous cell carcinoma and BCCs, we can do a shave biopsy.
Yeah, but is there a size criteria? Do you do it for such a large tumor, 5 centimeters?
Less than 2 centimeters.
Usually less than a centimeter or two. Okay, usually less than 1 centimeter you will consider. More than one, you will generally plan for a biopsy, because you can't just shave it and leave it like that. You need to have a reconstruction plan, right?
Yes.
So you don't do a shave biopsy or excision for this. You plan for a edge biopsy to get the diagnosis, and only then you do it. And locally, are you happy with only an X-ray of the skull, or do you want something else?
CT, sir.
Why do you want a CT?
To see intracranial extension.
Intracranial extension. You said the tumor is mobile in all directions.
Yes, sir.
So do you think it has an intracranial extension then?
No, sir.
I would like the opinion of the group on doing a CT of the skull for this particular patient if it is a mobile tumor as clinical examination for an exam scenario. Practically, I think most of us would do it, but in an exam, what would be the right answer for the candidate to give? Will they do a CT in a lesion which is clearly free from the underlying structures?
Shreya, what are the layers of the scalp? Then probably you can answer that, yeah. What are the layers of the scalp?
Okay. Skin, subcutaneous tissue, the periosteum, and the skull.
It stands by the SCALP. So what is that SCALP? S is skin.
Skin, subcutaneous tissue, loose areolar tissue. P is periosteum.
A is, what is A? Any
Areolar tissue, sir. Loose
yeah.
areolar tissue.
No. It is
That
for the
is
aponeurosis, no?
Aponeurosis.
What is that aponeurosis? Galea aponeurotica.
Yes.
So you want to see on that, even if it is a mobile tumor is there, if it is slightly fixed to the periosteum or not. Because if it is just fixed at one point, then still the tumor may be mobile. So that is why you should have the CT scan in this patient to see for that what is the depth of the invasion of this tumor. Okay, from that is my point of this one.
perfect, sir. I agree. I think all the panelists will agree, and in your exam, they will expect you to say a CT of the scalp to look for one is the bony invasion, and also for which is the deepest layer of invasion that you have, so that you can plan your surgery and your reconstruction as well. So before going on to a PET CT, I think you should say a CT of the scalp and the skull bones to look for the depth of invasion, not for just intracranial. Intracranial is unlikely given the clinical picture that you have. What you're looking for is till which layer is the tumor extending.
Yeah, if the periosteum is involved and you have to excise the periosteum, then what is the difference between the repair of that defect?
We'll do stripping of the periosteum, sir.
Yeah. So if you strip of the periosteum, you take out the periosteum, then does it make a difference in your reconstruction?
Flap cover, sir.
In which case?
If you strip the periosteum, and then we can do a SSG feeding.
Yeah. If the periosteum is intact,
Yes, sir.
you can simply graft that. Makes
SSG.
your option very simple. Okay. Otherwise, you have to carry out some type of the flap surgery there if the periosteum is not there. Okay.
Hello.
Dr. Shriya,
Yes, sir.
so basically,
X-ray ఒకటే పెట్టావు రిపోర్ట్ ఏం పెట్టలేదు.
regarding the biopsies,
Yes, sir.
if it's an purely ulcerative component, you go for incisional biopsy. If it's an exophatic component, you go for a punch biopsy or a wedge biopsy, right?
Yes, sir.
And if it's a very small tumor, you can, like say less than 2 centimeter, you can go for an excisional biopsy.
Yes, sir.
Now this edge biopsy, the edge wedge biopsy, it's better to avoid that term, and you can just say a punch biopsy or an incisional biopsy. And if you say that I would take a biopsy from the most representative area, avoiding the areas of necrosis and slough. So that would be the best definition or best statement to make.
Yes.
Okay, when they ask you like what type of biopsy will you take? Because you'll have the purpose of the biopsy is to take it from the area where there are proliferating cancer cells expected to be there, right?
Yes,
So
sir.
they are usually present in the edges. And if it's a flat lesion or ulcerative lesion, we usually take a part of the normal skin to differentiate it from the cancer cells. And we usually do not take it from center because usually the center is devoid of
Necrosis.
blood supply and it's necrosed usually. So that is the purpose of inventing this term. So you could always make this statement like this, like what I said. You take a biopsy, an incisional biopsy or a wedge biopsy or a punch biopsy because it's an exophytic lesion from the
Yes.
most representative area, avoiding areas of slough and necrosis. Okay.
Yes, yes.
Okay. So may I know like which textbook are you preparing from or you're reading from? Which year postgraduate year?
Third year, sir. Just.
Okay. So which textbooks have you used to prepare for this case?
So I just use Savastin, sir, and DAS.
Okay. So as does the chapters are very beautifully written. I think you should read it multiple times to get the hang of it.
Yes.
Okay, you should go through it thoroughly. And there are two other books also. One is Makhan Lal Saha, a textbook by Makhan Lal Saha, and there's another text. There's another. It's not a textbook. It's a compilation of cases. And there's another by Dr. Dayanand Babu. I think you should. These complement to the textbook of Esdas. Obviously, Esdas should be your Bible. So the other two textbooks will give you a more, shortcut questions and answers, right? So you'll have an overview of all the likely questions and answers you could get.
Dr. Shenoy is one of the panelists always. He's not there today. He has written very beautiful books on the Manipal textbook of surgery. That also
Yes,
gives
sir,
almost
sorry, I
everything.
could not mention the other textbooks.
Right.
Yeah, obviously I've read those books. I mean, Manipal textbook is very good.
Yes.
Yeah. So my point was to get SDAS as the reference and try to go through as many textbooks as possible. Yeah.
Yeah.
Now, tell us shortly, doctor, because we are almost at the end of the discussion. What would you do for this patient? You have found, you have done a CT, there is nothing on ultrasound. CT shows the growth, whatever it is confined to the skin and the subcutaneous tissue. No deeper extension is there. And there is no metastasis that you have made out on clinical examination and on your imaging, everything. The biopsy comes as squamous cell carcinoma. For the sake of making it a little easy for you to the end, let's say it is squamous cell carcinoma. What would you like to do for this patient?
Wide local excision giving up to 6 mm margin, sir. With if the periosteum is intact, then an SSG graft cover. If it is not, then a rotational flap, sir.
So you want to go till the aponeurosis and the periosteum and take, leaving the periosteum, you want to take the aponeurosis in all cases?
If it is greater than 5 centimeters, in my case, the upper periosteum is required, sir.
In your case, it is?
greater than 5 centimeters tumor, that is comes under high risk. So up to periosteum can be taken, should be taken.
Okay, for a high risk tumor, what is going to be the margin of excision, doctor?
If it is less than 2 centimeters, then 4 mm, sir. If it is greater than 2 centimeters, then it is up to 6 mm.
Doctor,
sir,
you already
margin.
said it's a 5 centimeter tumor. So
6
is 6
mm
mm
margin,
minimum, or do you plan for
6 to
1
1
centimeter?
6 to 1 6 mm to 1 centimeter margin, sir.
Yeah, I do know that Sebastian mentions its basis that it's 6 mm, but I think most examiners will want at least a 1 centimeter clear margin for you to proceed with the excision. And the plan of reconstruction, as you said, you're going to do a skin graft if the periosteum is intact.
Yes,
If
sir.
not, you will do a flap. What kind of flap will you use? Suppose you need to take the periosteum for whatever reason, it is stripped off. What will be the flap that you would like to use?
Transposition flaps. Rotational.
What is the difference between transposition and rotation? See, doctor, these are common scenarios that you will come across. See, the moment you have this case, you know that questions will come on scalp, on layers of scalp, on spread to lymph nodes, on the surgery that you're going to do, wide excision, on margins. And when you do wide excision, then on the flap, what kind of flap? So you should know basics about what are the flaps that will happen. So it is just thinking logically whenever you're facing an exam. In fact, to add on to the books that have been suggested here, I will think there is another book of surgical cases by Dr. Raja Mahendran, I think, where he addresses specifically each of the questions and lists you. That's a very, very shortcut kind of method, which you should do at the end just before the exam, after reading everything. It is very logical. You just need to follow these steps. So you have this, you have this, you have this. Then what? Then what? Then what? In fact, you can make a list of those questions and you can have them so that whenever the examiner asks, you can just go tuck, 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 and that is what will make you clear the exam in general.
Yes.
And again,
Dr. Shia, regarding margins, I would like to add some points. So whenever they ask you about margins, you should always think in terms of 3 dimensions, okay? So it's not only the lateral margin, it's also the deeper margin in this case, right?
Yes.
So when you talk about, again, when they ask you about the margins in measurements, you should always say that the margins which you're reading in the textbook and all, no, they mention the microscopic margins, which is available in the histopathology report or in the frozen.
Yes.
So you should say that I'm aiming for a microscopic margin of 6 millimeters. In order to get that, you would give a gross margin when you're doing the surgery of at least 1 centimeter, because there'll be a 30% shrinkage of the specimen. So calculating that 30% shrinkage, you would say, you'll have to say that I will give a gross margin of 1 centimeter so that I would get a microscopic margin of more than 6 millimeters. Okay, so be clear about this.
Yes,
All the margins which are mentioned in the textbooks, it's microscopic margins, not the gross margin when you're planning the incision. Okay.
Yes, sir.
and is there any way you can do this? Suppose it is close to, let's say, the upper eyelid. Suppose it's more of an anteriorly located swelling or ulcer, and you need to do the same thing where it is at the eyebrow, for example. And giving that 1 centimeter margin will actually come on to the eyelids, for example. So do you have any other method that you can do to sort of help you with the excision or change the excision pattern that you will have here? You cannot give a 1 centimeter margin because vital structures are nearby. Dr. Shia, you're there?
Okay, I think we can close this case. So would you like to just tell the students how they should go about taking a history and examination of this case in a brief manner, and where this girl could have improved? Dr. Balaji, sir? Hello?
Yes, I think I think we can close the case, sir. I agree, sir. She did the decent job, but the only thing is she got flustered. The history was reasonably accurate, but as you mentioned, she needed to be more detailed in her thing, and to get an idea of how you should be a little more doing an in-depth analysis of the history rather than taking things at face value. So that is one point you brought out very clearly on the history, when uh, she didn't know whether there was an ulcer, whether there was a laceration, whether it was sutured, whether there was repeated trauma. So these are the sort of things that will kind of put us down in an examination. So we need to pay attention to it. Now, these kind of cases, it's also good to be ready with a short history and a short summary, because most of the times these will come as short cases at the end where they will just say, okay, summarize your history. So we need to have that ready as well with the salient features in terms of whatever is there in the history which might be relevant. Like here, it might be a long-standing swelling, a history of sun exposure, farmer by occupation, proliferative growth. So all these are things that I might be wanting to say. And as Dr. Vijay already put it, think of it in terms of etiology, as in symptoms, in terms of etiology, in terms of risk factors, like that, and again in terms of metastasis and other symptoms. So that is the way you categorize and you take it forward. If we do that, I think they will have a pretty good idea of covering everything. And examination part, again, we need to spend a little more time in kind of highlighting the points. She made all the points, but then the induration she wasn't mentioning, which is a key point there. So the key pointers need to be listed out, and that needs to be mentioned, particularly stressed upon, and that will put the examiners in a very clear idea of what they are suggesting. So these are the points that I would like to suggest, sir, and I think that's
Okay,
about
Dr.
it, sir.
Shreya, do you have any questions to ask? Any queries?
No, sir.
Okay. Could you just stop sharing your screen, please?
Yes, sir. Thank you, sir.
And I would like to call on Dr. Sana from GMC Tirunelveli, and she's
Yes,
going to
sir.
present
Good
a
evening,
case.
sir.
Good evening, sir. Let Dr. Right, you can share your screen, please.
Yes, sir.
Dr. Sana. Right. Please go ahead.
Is it okay, sir?
Yes, please, we can see it.
Good evening, faculties. Myself, Dr. Sana from Tirunelveli Medical College. My HOD is Dr. Babita Devi ma'am, my chief Dr. Kamlan Vijay ma'am, and my assistant professors Dr. Vinodan, Dr. Michael sir, and Dr. Mohammed Abdul Majid. I'll start with the case presentation. A 75-year-old gentleman coming from Tengazi, who is daily wage by occupation, presented with complaints of ulcer over the tongue for 6 months and difficulty in swallowing for 1 month. History of presenting illness. The patient was apparently asymptomatic for 6 months, after which he developed ulceroproliferative growth over the left side of tongue, which was insidious in onset, initially small in size and gradually increased to the current size. History of difficulty in swallowing present for 1 month. History of difficulty in chewing for 1 month. History of difficulty in speaking for 1 month. History of drooling of saliva present. History of halitosis present. History of difficulty in protrusion of tongue present. History of loss of weight and appetite present. No history of pain. No history of difficulty in opening mouth. No history of sharp tooth. No history of cough or breathlessness. Past history. No history of previous ulcer in oral cavity. Not a known case of diabetes mellitus, systemic hypertension, CAD, bronchial asthma, tuberculosis or epilepsy. No history of any dental surgery. Personal history. He consumes mixed diet. Sleep is adequate and undisturbed. History of smoking BD for 50 years present, 10 BDs per day. History of alcohol intake for 50 years, 180 ml per day. And history of betel liquid chewing for 20 years. Summary.
Yes.
A 75-year gentleman who is a chronic smoker and betel quid chewer and an alcoholic presented with a painless progressive ulcer over left tongue for 6 months. So it's a case of non-healing ulcer of tongue, probably due to malignant etiology.
Okay,
Dr. Sana, can
Sana,
you go back to the chief complaints?
Yes,
So complaint of ulcer over tongue, would you like to ask him, like, would you like to mention here which side or which border of tongue, whether it's an anterior part or posterior part?
yes, sir.
Would
It
it
is
be
over
added in the
the
chief complaints? Yeah.
Yes, sir. It is actually over the left lateral border of his tongue.
Okay. So
Yes,
that was
sir.
there for 6 months, but he developed difficulty in swallowing only for
Like
the
for the past 1 month.
last 1 month. Okay.
Uh,
So
Excuse me, sir.
at this,
Sorry to
yeah.
interrupt. I've just been called away on an emergency. So, excuse me kindly and please carry on. All the best, Dr. Sana. I would
Thank you,
probably
sir.
pick up the questions to Dr. Kanagvel on some relevant points if they have not been covered by this one.
Okay, sir.
Thank you,
Thank you.
Dr.
Thank you.
Saloni. Yes, sir.
Thank you for this wonderful session again. Thanks.
Thank you. Thank you, sir. Yeah.
Yes. So,
Yes,
Dr. Sana.
Aditi.
Yes,
Yes,
sir.
sir.
So at this point, what do you think of, you have to formulate differential diagnosis at two areas, like one after the chief complaints, one after your whole history and physical examination. So this is what I would suggest. So at this point, you have to make your broad differential diagnosis. So what is the differential diagnosis at this point after chief complaints?
After the chief complaint, it is a chronic non-healing ulcer. And with the history that
Good.
I've elicited, I would like to put it more towards malignant etiology, sir.
No, not the history. No, just after this, after inquiring this chief
Okay.
complaint, what would be your differential diagnosis?
Since there is difficulty in swallowing, I can put it into either the ulcer is involving the posterior third of the tongue, which is causing the difficulty in swallowing, or there is infiltration of the tongue muscles till the floor of the mouth, which might be contributing to the swallowing difficulty.
Yeah, good. Yeah, those are good points. So 75 years old, statistically, patients having ulcer over the tongue for 6 months, which has not healed. And furthermore, he has developed some complication like difficulty in swallowing. So
Yes, sir.
statistically, I would put, I would think of a malignant ulcer to begin with, which
Yes,
has
sir.
progressed to some complication, right? Like as you said,
Yes, sir.
involving the floor of muscles or the back of tongue. And also, I have an idea that where the ulcer is, even though I have not mentioned, because the
Yes, sir.
swallowing is affected, it must be probably the parts which are involved in the swallowing, the posterior one
Swallowing.
third of tongue, yeah, or the
Yes,
tonsillolingual sulcus, or the palate, or whatever the pharynx. Yeah, please
yes,
go ahead to the next slide.
yes. Presenting illness, sir.
Yeah, so you have already mentioned this. Fine. So he is having difficulty in chewing and difficulty in speaking
And
also.
speaking. Yes, sir.
Okay. So based on this, what is your inference?
Sir, definitely there is a tongue muscle involvement, sir, altogether. He's having difficulty in swallowing and difficulty in chewing and in speaking. So put together, there is a tongue muscle involvement, which I can tell it for sure.
Okay, next slide.
Yes. History of drooling of saliva present. So
Yeah,
again, when he,
can you just give me an inference of all this?
so basically he's not able to, the tumor is big enough, which is which is putting him in a position where he can't swallow the saliva, and he's having difficulty in protrusion of the tongue.
Okay, halitosis.
Sir, because of the stagnation of saliva, there is a bacterial presence for a long time as he's not swallowing the saliva, which is causing halitosis.
Okay, salivary pooling. There could be
Pooling, yes,
slough
sir.
also. Slough over
Slough.
the ulceroproliferative growth. Necrotic areas may be there.
Necrotic area.
Yes.
Yes, sir.
Okay. Protrusion of tongue you already mentioned. It could be due to the involvement of the muscles of the tongue or the floor of mouth.
Yes, sir.
Right?
Yes, sir.
Okay. Loss of weight and appetite probably is ignored this ulcer for a long time.
Okay. Yes,
Which
sir.
is causing the systemic symptoms. Okay, next
Yes.
slide.
No history of pain, sir.
Okay, so this history of pain in CA tongue or expected, anticipated malignancy of tongue, this gives rise to a lot of questions.
Yes, sir.
So is this the pain over the ulcer you're talking about, or is this a referred pain?
I've put it generally, sir. He's not having both pain in the ulcer and not a referred pain also, sir.
So when you talked about difficulty in swallowing, is it difficulty in swallowing or painful swallowing? Or both?
Difficulty in swallowing, sir.
So you mean to say it's painless?
Painless, sir.
So it's highly unlikely actually,
Okay,
because
sir.
he would have some pain while swallowing, because he has having ankylosing glossia and the posterior tongue is involved. So definitely the nerves would be involved, and the musculature would be involved, and that could cause pain. Okay.
Yes.
So do you want to say something about referred pain?
Sir, if at all there is referred pain, it could be due to malignant infiltration of the lingual nerve, which is being radiated to the auditory canal through the auriculotemporal nerve, sir.
So where does it radiate to?
It radiates to the ipsilateral ear. It presents as
Fine.
earache for the patient.
Fine. So first we have to divide, when you talk about the nerves, you have to divide the tongue into three parts, right?
Yes, sir.
Which have three different nerve supply, and the radiation occurs to three different sites.
Yes, sir.
So are you aware of that?
Yes, sir.
Could you elaborate on that?
Yes, sir. Actually, the tongue nerve supply, we can divide it into three, sir. Anterior two-third of the tongue, posterior, and posterior most. In anterior two-third, we have the nerve supply, lingual nerve and chorda tympani nerve, sir. Lingual nerve is for general sensation. For a posterior one-third, it is a glossopharyngeal nerve for both general sensation and taste. And for posterior most, it is vagus nerve, sir. So when coming to the anterior two-third of the tongue, as there is when the lingual nerve gets involved, it gets radiated along the course of auriculotemporal nerve, sir. As both of them have the common branching from the trigeminal nerve through the mandibular branch. In posterior one-third of the tongue, it is a glossopharyngeal nerve, sir. Here we have a radiation of the pain to, radiation of the pain to the throat, sir.
Okay, just finish it off. I'll explain. Yeah. What about the posterior most?
Posterior most, I'm not aware, sir.
Okay. Yeah, so you're right about the nerve supply. So the anterior part of the tongue, if it involves the lingual nerve, you'll have more pain in the external ear. Okay. So as you go posterior, the pain would be more deep-seated pain.
Yes, sir.
Okay. So can you tell me two more sites where you can get referred pain to the ear? Two more sites in the oral cavity.
Okay. I'm not sure, sir.
So if you have a problem in the dentition, okay?
Dentition. Yes, sir.
Yeah. So teeth is one area where you can get referred pain to.
Referred pain to the ear.
The ear.
Okay.
Yeah, because the nerve supply, lingual nerve branches also supply to the mandible and the alveolar processes. And another area is in the oropharynx, right?
Oropharynx. Yes, sir.
Yeah. So the accessory complex would supply the pharynx, and then that communication would also give rise to referred pain, right? Even tonsils. Again,
Yes, sir.
glossopharyngeal supply to tonsil and the ear. So you can have referred pain to the ear.
Okay, sir.
Okay. So difficulty in opening mouth, when does that happen?
When there is infiltration into the buccal mucosa causing trismus, there
Is
can be
buccal
difficulty
mucosa
in opening.
responsible for opening the mouth?
No, sir. It is when the palatine muscles are involved and the pterygoid plates are involved, it will cause a difficulty in opening of mouth.
Usually, opening of mouth is the function of muscles, right?
Yes, sir.
Yeah. So those are the masticatory muscles. Can you name them?
Yes, sir. Masseter.
Yes.
Masseter, palatoglossus, and pterygoid.
It's actually medial pterygoid, lateral pterygoid, masseter, and temporalis. Okay.
Temporalis. Yes.
Yeah. The palatoglossus, pterygopalatine plates, and all don't come here.
Okay.
These are the four muscles. If the growth involves any of this, then you'll have difficulty in opening the mouth. Okay. And there's another reason for trismus, that is due to pain. Sometimes due to pain, they don't open the mouth. So you will have to differentiate whether the trismus is due to infiltration of these muscles, which makes it a very locally advanced tumor, from the trismus, which is due to pain.
Okay, sir.
So how do you differentiate it? Any idea?
Can maybe by, I'm not sure, sir, but can we give a painkiller and anesthetic after giving local lidocaine? We can ask the
So
patient.
after analgesia, patient will be able to open the mouth. And as sir has mentioned, submucosal fibrosis is another cause of trismus.
Another cause. Yes, sir.
So how do you differentiate the trismus from submucosal oral submucosal fibrosis from a trismus from infiltration of masticatory muscles?
Sir, by digital palpation of the cheek,
No, from the history. What do you ask him?
I can tell about whether there is history of beetle nut quid in mouth, risk factors, from the history of risk factors.
No,
Whether
can
he
you
has been
differentiate?
using.
You need to ask a question to the patient
Okay.
by which you will know whether the trismus is due to tumor or the trismus is due to submucosal fibrosis.
Not sure, sir.
Okay, so oral submucosal fibrosis is a pre-malignant lesion. Agreed?
Okay. Yes, sir.
Yeah, so it is going to be long-standing, which could give rise to this tumor, right? So
Yes, sir.
patient would be having trismus before the development of the growth,
Okay, sir.
if
Yes,
it was due to the submucosal fibrosis. So
fibrosis.
you'll have to ask him whether the difficulty in opening of mouth developed after the growth or before the
Or
growth.
before
So
the
that would give you an idea. Fine.
yes.
Okay. So why did you ask about sharp tooth?
Sharp tooth would have caused a repetitive trauma to the tongue and the buccal mucosa, which is a risk factor for developing oral cavity malignancy, sir.
So since you asked sharp tooth, you can enumerate the 5S causes of
Yes.
the ulcero-proliferative growth. Yeah.
Yes, sir. Spicy food, sharp tooth, syphilis, smoking, and fifth one.
Fine. So then you have jumped to the metastatic symptoms. Go to the
Yes.
next slide. Okay, so that's it.
Yes, sir.
Fine. So you have asked about the possible risk factors, and
Yes.
you have also enumerated the symptoms, which
Yes.
could tell us about the possible complications which the ulcer has developed into, and you have asked some questions related to the stage of the disease, right?
Yes, sir.
So that is fine. Would you like to chip in, sir? Anyone?
Yeah, please. Dr. Sana, this is Dr. Sai.
Yes, sir.
Did you ask about any pre-malignant conditions he had before this ulcer?
If I asked if there was any previous ulcerations in his tongue, sir, before the 6
Any
months.
discoloration, this thing of leukoplakia or erythroplakia, any discoloration, any other thing? You have
Yes,
to
sir. I
mention
had
this as a
that's
negative history,
negative history.
right?
I
Okay,
put
about swallowing, was the swallowing painful or painless? Was it only to solids? Was it only to liquids? Was it to both? Did, uh, uh, all this has to come out in your history, right?
okay, sir.
Also about teeth, you said just dental surgery is not important.
Okay.
More important is that does he have his full dentation? Does he have a history of recent fall of teeth?
Yes, sir.
Right, all that has to come.
Yes, sir. I mentioned. Yes, sir.
And pain, sir, has discussed already with you. That is important, right? Should we go to the examination or anyone else? Okay, Sana, let's go to the examination then.
General examination. After getting informed oral consent from the patient, he was examined from head to foot in a well-lit room with privacy. Patient is comfortable at rest, moderately built, poorly nourished, hydration fair, no pallor, cyanosis, icterus, clubbing, pedal edema or generalized lymphadenopathy, BMI 16.6. His vitals were stable, BP 120/80, pulse rate 88 per minute, respiratory rate 14, and afebrile, temperature afebrile. Inspection. Patient examined in the sitting position. The lips are normal, mouth opening adequate, oral hygiene poor, halitosis present, nicotine staining present, dental score only the left upper lateral incisor tooth is present. An ulceroproliferative lesion of size approximately 7 cross 10 centimeter involving the left lateral border of the tongue, extending anteriorly 3 centimeter from the tip of the tongue, medially up to the midline of the tongue, laterally extending into the gingivobuccal sulcus, lower alveolus, and 3 centimeter into the left buccal mucosa. Posteriorly, it is visible beyond the anterior tonsillar pillar. No bleeding, ankyloglossia present. Inferior aspect of the tongue could not be seen due to ankyloglossia. Deviation of the tongue to the left side on protrusion of the tongue. The palate is normal. Uvula is in midline. Skin over the cheek appears to be normal. And the dental formula, only the left upper incisor is upper lateral incisor is present. Palpation, tenderness present on palpation over the ulcer. An ulceroproliferative lesion of size 7 cross 10 centimeter involving the left lateral border of the tongue. Again, extending anteriorly 3 centimeter from the tongue, medially up to the midline. Laterally, it extending into the gingival buccal sulcus, lower alveolus, 3 centimeter into the left buccal mucosa. Posteriorly, it is involving the posterior 1/3 of the tongue, left anterior tonsillar pillar, left retromolar trigone. With the posterior limit of induration, it is not fully palpable. Margins are irregular, everted edges, base indurated, and induration does not extend beyond the ulcer. Does not bleed on touch. Ankyloglossia present. Inferior aspect of the tongue not palpable due to ankyloglossia. Right side of the tongue, buccal mucosa, retromolar trigone, normal. Examination of neck. A single 2 cross 2 centimeter hard fixed non-tender node palpable in the left submandibular region. 2 cross 1 centimeter firm hard non-tender non-palpable node palpable in the right submandibular region. 1 cross 1 centimeter firm hard mobile non-tender node present near the upper 1/3 of the sternocleidomastoid muscle level 2. So left level 1B, right level 1B and level 2 nodes are present, no other nodes palpable. Other system examination, respiratory system bilateral normal vesicular breath sounds heard, CVS S1 S2 heard, per abdomen soft, no organomegaly. Summary, a 75-year gentleman who is a chronic smoker, betel quid chewer and an alcoholic presented with a painless progressive ulcer over the left tongue for 6 months. On examination, ulceroproliferative growth noted in the left side of the tongue, extending into the floor of mouth, buccal mucosa, anterior tonsillar pillar with posterior limit not definable, and bilaterally cervical lymphadenopathy. Diagnosis is a case of carcinoma tongue, clinically T4A, N3B, and M0.
Okay, so now we'll go back to the examination and we'll see one by one.
Yes, sir.
Go to the general examination.
Yes, sir.
So what do you think is the most important in general examination? Why do you want to know? What do you want to know and why do you want to know?
Okay. First, whether the patient is having, whether how he is moderately built or poorly built, his nourishment, whether he's anemic or not, whether jaundice is present or not, to know about whether he's in the cachextic state, how his general condition is.
So first thing is nutrition, right? So you want to know about
Yes,
his
sir.
nutritional status.
Nutrition.
So why do you want to know the nutritional status?
Whether this lesion is causing any difficulty in his nourishment, sir, whether he's not able to swallow properly, and
So that is an obvious sequelae of such a advanced lesion. So what other
yes, sir.
implication it has? Why do you want to know the nourishment status related to the treatment? Anything?
For planning treatment, yes, sir. For planning treatment, we should know the patient's status, sir, general condition.
Yeah. Okay, fine.
Whether he will
It is usually it's a general it's applicable for all cases, all majors which has to undergo major surgery, especially in cancer patients, right? So
Okay,
nourishment is very important. Only then he would be fit for any surgery
any
or
surgery.
fit for any modality of treatment for cancer. So if you
Yes,
know that he's not having a good nutrition, so you'll have to build up his nutrition,
yes, sir.
okay, before surgery or before any kind of adverse treatment. So that is very important. That is
Yes,
why
sir.
you ask for that. And anemia, of course. So all this you'll have to see whether there are any factors which are deviating from the normal range so that you can optimize them. Okay,
Okay. Yes,
like
sir.
anemia. If it's dehydrated, you'll have to hydrate him. If the nourishment is poor, you'll have to optimize his nutrition.
Optimize the patient prior to the management.
Fine. Next slide.
Yes. Sir, is
Okay.
Okay, sir.
So can you tell me the grades of trismus, or how do you grade the trismus?
Sir, clinically by 3-finger test, whether we are able to insert 3 fingers when he opens his mouth, it is normal. If only it admits 2 fingers, it is grade 2. If admits only 1 finger, it is grade 3, sir. Otherwise, we can by measurement, if it is more than 3.5 centimeter, it is normal. 3.5 to 2.5 centimeter, it is grade 2. 2.5 to 1.5 grade 3, less than 1.5 grade 4, sir.
Yeah, very good. So there are two methods. One is finger method and another is the centimeters measurement, right? Okay. So poor oral hygiene, halitosis, nicotine staining. So one thing which you have left out, yeah, you have mentioned the dental score. Fine. So dentition, whether it's edentulous or not. Fine. Next slide. Next slide. Yeah.
Yes.
Okay. So go back to the previous slide. So I think go back to the previous slide. Inspection. Yeah. So can you tell me the parts of the oral cavity?
Yes, sir. So oral cavity, it extends from the vermilion borders of the upper and lower lip anteriorly, posteriorly up to the posteriorly up to the posterior one third of the tongue, superiorly up to the junction of the hard and soft palate, and the anterior
Okay.
tonsillar pilus.
Fine. Can you tell me the parts of the oral cavity now?
Yes, sir. Lips, tongue, buccal mucosa, alveolus, floor of mouth.
Okay, you have to add up gingivobuccal sulcus and gingivo-labial sulcus also. Okay, and the hard palate.
Yes, sir. Hard palate.
Yeah. So basically, whenever you're examining or inspecting or palpating the oral cavity as such, you will have to mention about all these sites. Also, when you're palpating the tumor, when you're talking about the extent of tumor, again, you'll have to mention all this, right? So again, when you're talking about the extent, you have to go one step beyond laterally. From the buccal mucosa, you have to go into the masseter muscle, sorry, the buccinator muscle, and then the skin. Okay, that is to know the extent laterally also. So you have to include these also during palpation. So let's come back here. So one thing which we need to always include in inspection is the pre-malignant lesions, if you find any.
Oh.
So you have to always say that there was no leukoplakic patch or erythroplakic patch, okay, or any whitish patch in the oral cavity. Which are the common sites you look for this pre-malignant lesions?
Sir, tongue, floor of mouth, and buccal mucosa, sir.
Yeah, commonly it's the buccal mucosa where you can find the velvety patches indicating submucosal fibrosis depending on the stage, or the erythroleukoplakia. Okay, other than buccal mucosa, it's the tongue and floor of mouth, as you said. Next slide.
Sir. Yes. Sorry, sir, 1 minute. I'm not able to navigate, sir. Just. Yes, sir.
Okay, you have mentioned the extents.
Yes, sir.
It's okay. Fine. We'll do one thing. We'll go to the palpation and then we'll discuss on that because it's going to be the same.
Yes, sir.
Since you mentioned the dental formula, so what is it based on? Can you tell me what is the dental formula?
Yes, sir. Actually, this is the universal formula where we mention the 32 teeth with the dental formula 3123, sir.
It's not 3123, it's 2123.
123.
This is where you get caught up, there was no need to mention the dental formula. Now I got you. So it's 2123. What is it? Which teeth?
Incisor, canine, premolar, molar teeth, sir. Hello.
Yeah, I'm back.
Yes, sir.
Yeah, so have you gone to palpation? Yes.
Yes, sir.
Okay, so how do you palpate the tongue?
Yes, sir.
Which position?
Sir, I didn't get it, sir.
So let's say
How? I didn't. It was not audible, sir. Hello, sir. Hello, sir.
are you able to hear me?
Yes, sir. Now I can hear you, sir.
Oh, sorry for the.
Yes, sir.
So yeah, supposing he is not having ankylosing, would you ask him to protrude the tongue and then palpate properly all the extent?
No, sir.
Or would you
Because
not do that?
Because protrusion of the tongue will put the muscle into tension, which will itself mimic in a feel of induration, sir. So
Fine.
it
Yeah,
is
yeah,
better to
that's
keep
good. So
yes,
always you palpate the tongue in the resting position inside the mouth.
inside the
Okay,
mouth.
so that induration can be better appreciated, right?
Yes,
So
sir.
that is one thing which I wanted to tell you.
Yes, sir.
So you have mentioned here that the posterior limit of induration is not fully palpable. So what do you mean? What is the inference?
It is extending beyond the posterior 1/3 of tongue, sir.
Fine. So based on the history, I would infer that it initially started in the left lateral border and then it has progressed to involve the posterior third of
1/3.
tongue also, right? Okay, next slide.
Yes.
Okay, so there is a level 1B node and there's a contralateral node also,
Yes,
and there's
sir.
a level 2 ipsilateral node. So
Yes.
why do you think the patient has developed a contralateral node?
Sir, because the tumor has grown and has involved the anterior, almost till the tip of the tongue, sir. So there is bilateral node involvement, sir. And it is there up to the midline, and floor of mouth is also involved in this case, sir. All have a higher propensity for a bilateral nodal spread.
Yeah, correct. So first thing you have to tell is the midline. It has breached or crossed the midline or it almost touched the midline.
Yes, sir.
Secondly, the floor of mouth is involved. So
Yes.
floor of mouth, irrespective of the side, it can go to both sides of node.
Yes, sir.
Okay. But the tip is not involved here because you
Not
mentioned that
involved, sir.
3 centimeters from the tip. Okay.
Centimeter.
So how do you examine the neck, in which position?
In a sitting and flexed position so that the muscles are put into relaxation. I will stand
Where would
behind.
you be standing? Yeah, okay,
I'll be
behind.
standing behind the patient.
Okay. So
And
in that position, which level nodes would you palpate?
in flexion, I'll go for a submental and submandibular nodes, sir. And for palpating the lateral nodes 2, 3, and 4, I'll put the patient into movement in that direction so that the ipsilateral sternocleidomastoid will be relaxed.
Yeah, so level 2, 3, 4, and 5 also
Yes.
standing behind the patient. But submental and submandibular, you can stand in front of the patient, ask him to flex the neck and also palpate. You will have a better feel. And also to differentiate the mandibular nodes from the submandibular gland, you will have to stand in front of the patient, right? Because you'll have to
Yes.
do what?
I have to do by manual palpation, sir.
Is it by manual or by digital palpation?
By manual, sir.
You're going to put the whole hand inside?
No, sir. Actually, I'll use one hand outside and maybe a finger of the other hand. Using one hand,
Yeah.
I'll push the mandibular gland and try to feel it with the other hand's finger
So you
inside.
put one finger inside in the floor of
Yes, sir.
mouth and one finger outside,
Outside.
and you try to, find out if it's the gland. If it's a gland, what would be your finding?
I will be able to palpate the deeper part of the gland, sir.
From inside also. Okay,
Yes.
fine. Next slide.
Yeah.
Okay, next slide.
Somebody.
So what are the points in favor of a CA tongue malignancy?
Yes, sir. Here, it is a short duration and chronic.
Let's start with
Patient
the
has
age of the patient,
age of the patient.
occupation, sex.
Risk factors, sir. This is chronic smoker, beetle, with chewer, and it is associated with symptoms that suggest infiltration, sir. Uh, Difficulty in swallowing and protrusion of tongue. And in examination, it is ulcero-proliferative hard lesion with it has extended beyond the tongue. It has gone to the alveolus mucosa.
Okay, what else?
No nodal involvement is there, sir.
Yes. So you have to follow a particular format when somebody asks you what are the points in favor of malignancy. You have to start with age, 75 years, common age for carcinoma. Sex, again, a male patient, more prone. Okay. Occupation, what is his occupation?
It's a daily wager, sir.
Okay. Is it relevant?
Um, Yes, exposure to smoking.
Okay, you cannot generalize, but usually, they will be more associated with these habits. Other than that, you cannot really relate it. And then you come to the habits, okay, chronic smoking. Again, you have to mention the pack years, okay, cigarette pack years, cigarette or BD, first of all, and then pack years. How
Yes.
many packs he smokes per day into number of years.
Yes.
Beetle nut or beetle quid chewer, okay.
Yes, sir.
And what else? You can also mention it as a tobacco chewer or tobacco smoker, okay. Tobacco can be chewed also, tobacco can be smoked also. So again, alcohol. So then you come to the symptomatology. Okay, it's a chronic ulcer, the duration. Even though it's more than 3 weeks, but it's 6 months, it's rapidly progressed to this much advanced stage.
Yes.
So again, that's a point in favor of it. Then in examination, you mentioned that it is indurated lesion and it is involving the adjacent structures and then the nodal involvement, right? Okay. So do you want to give any other differential diagnosis?
Uh, no, sir. I think it is more towards carcinoma.
You want to give or you don't want to give?
No, sir. I don't want to give, sir.
Usually, CA tongue would not have any differential diagnosis. Okay? So you can just say that, okay, this is the only diagnosis because all the points are in favor of malignancy.
Yes, sir.
And next slide.
Yes, sir.
So
Diagnosis.
before we go on to the management, sir, anybody would like to add something?
Yes. Dr. Sana,
Yes, sir.
how is induration important in CA tongue?
Yes, sir. Because when we are planning for surgery, we have to give clearance from the site of induration, sir.
So, right. So, can you think of another malignancy where induration is much more than the site of lesion?
um,
In CA penis, right?
yes,
The induration is much more. So similarly in the tongue, the induration is much more beyond, because you've mentioned that there's no induration beyond, which is
yes,
slightly
sir.
unlikely.
Okay, sir.
Please, sir.
Yes, sir.
Okay, so diagnosis with staging. Very good. This is how you'll have to give a diagnosis. Okay. Can you move to the next slide? Yeah, before that, yeah, can we have some discussion on the staging? Do you want to have a discussion on the TNM categories?
Yes, sir.
Okay, so first of all, you don't call it T staging, N staging, M staging. Okay,
sir.
that's what we wrongly have been doing it. It's a T category, N category, M category. When we call it a staging, it is the combined stage. Okay, stage 1, 2, 3, 4. So we should not call it actually T stage, N stage, M stage. It's a T category, N category, M category. So remember this. So why do you say it's T4A?
Sir, because it is more than 4 centimeter, and why I'm telling it is A is because it has involved the adjacent muscles. So I have put it in T4A, sir.
Okay, less than 2, 2 to 4, more than 4.
More than 4.
And then 4A, 4B. 4A is involvement of
Muscle, skin, adjacent alveolus, and mucosa, sir. In T4B, it is involvement of carotid, pterygoid spaces, internal carotid artery, uh, base of skull.
Okay, good. So basically, why we categorize this into T4A, T4B is T4B is generally unresectable. Okay, because
Yes,
it's
sir.
involved the masticator muscles and beyond, either into the skull or down below into the prevertebral fascia. Right. So we will not get a good margin. It will always be a positive margin resection.
Yes, sir.
So T4A is resectable, but what it indicates is it's a very locally advanced tumor. Okay. So the prognosis is bad.
Yes, sir.
So once some oral cavity tumor involves the node, the survival drops by how many percentage?
I am not sure, sir.
Okay, you don't know. So it drops by 50 percentage. So you can imagine how bad the oral cavity diseases are. Okay. So this is generally applicable to other cancers also. Once the tumor involves a node, the survival drops by 50%. So again, it's a prognostic indicator. Okay, not only just a
Yes.
single involvement of node is dropping the survival by 50%. Imagine this patient's having an N3B. So what is an N3B?
N3B is more than it is an involvement of bilateral and
Start with
contralateral
N1. Start with N1. N1
nodal.
is
Okay, sir. N1 ipsilateral node less
single
than
ipsilateral, right?
single ipsilateral node less than 3 centimeter.
Okay.
In N2, 2A, 2B, 2C, sir. In 2A, we have a ipsilateral node 3 to 6 centimeter. In N2B, we have multiple ipsilateral node, everything less than 6 centimeter. In N2C, we have either bilateral or contralateral nodes less than 6 centimeter. In 3A, we have nodes more than 6 centimeter and without extranodal extension. In 3B, we have nodes with extranodal extension, sir.
Okay. Why do you say the patient's having extranodal extension clinically? How do you say?
Sir, the node is fixed, sir. Clinically, it is.
Okay. What are the other indications?
Ulceration of the node.
Okay. The skin may not be pinchable or ulceration. As you said, the nodes may be matted. Okay, it may be fixed to the sternocleidomastoid or the
Yes,
spinal accessory nerve may be involved. Okay,
yes.
clinically you can have some features suggesting of involvement of the nerve. Okay,
Yes, sir.
so N1 is single ipsy up to 3 centimeter, N2 ABC single ipsy, multiple ipsy, bilateral, all up to 6 centimeters, and N3A is more than 6, N3B is ENE, right?
Yes,
Why
sir.
do you say it's M0?
Sir?
Why do you say it is M0?
Sir, clinically, there is no signs of metastasis, sir. Like for chest, I asked about coughing, hemoptysis. There is no bone
What is the
pain.
most common site of metastasis in oral cavity CA?
Lung, sir.
Okay, so you don't find anything clinically there.
Anything
That's why your label
yes,
is M0. Okay, next
M0.
slide.
Yes, sir.
So what do you want to do first?
First, I want to confirm the diagnosis, sir. I have to make a
Okay.
pathological diagnosis by taking an edge biopsy.
Okay.
And along with the USG neck for confirming to look for the lymph nodes and a guided FNAC to prove the lymph nodes are metastatic or reactive nodes.
Do you think these nodes would be reactive?
No, sir. As it is fixed, it is.
Is it always needed FNAC from lymph node to prove it?
No, sir.
Maybe in a case of thyroid, you will require it, but in oral cavity, it's not mandatory. Okay.
Okay, sir.
So edge wedge, you were there for the previous case?
Yes, sir.
Okay, so is it edge wedge biopsy or would you like to put it in a different way?
Incisional biopsy.
It's a big growth, right? Yeah, punch biopsy or incisional biopsy from where?
Sir, from the tumor, which is not necrotic, along with the normal tissue, sir.
Fine. It's not necessary that you should always have a normal tissue. It's a big growth, right?
Okay,
If
sir.
it's a very small growth, if it's an ulcer, then you would probably take it at the edge. Okay.
Okay,
So
sir.
this you can just take a punch from the area which is having no necrosis or the
Okay,
area
sir.
which is having proliferation. Okay. The
Okay,
bright
sir.
red or the angry vascular area. Fine.
Yes, sir.
So now you're taking a biopsy, you have a pathological proof.
Yes, sir.
What else you want to do?
Sir, now I have to stage the disease and for planning the management, sir. Clinically, for this patient, the tumor looks to invade actually it is over the lower alveolus, sir. So I have to make sure whether it is involving the mandible or not. For that purpose and for staging the disease also, sir. I have to go
Okay.
for
So
a higher imaging like MRI oral cavity and
you mentioned
CECT.
you mentioned MRA and CECT. So what would you like to do, MRA or CECT?
Sir, in this case, I'll do both, sir. Because
So
MRI is to look for
necessary.
the.
Okay, what
Sir?
is your purpose in doing an imaging now? You already know clinically that it is involved the floor of muscles, back of tongue, right? You want to know
Yes, sir.
whether bone is involved. Mandible
Yes,
is
sir.
involved.
Mandible is
Clinically,
involved.
it's not involved, but you want to know whether it's bone
No,
is
whether it is
involved,
involved.
right?
Yes, sir.
So therefore that you will do CT or MRI.
CT, sir.
Then why have you mentioned MRI?
MRI to look for the soft tissue involvement,
But it's
tongue
very
muscle.
evident clinically, right?
Yes, sir. It is evident clinically. To look for
So
the
in
space.
other words, when would you do an MRI? When would you do a CCT?
Okay.
Do you have an idea?
MRI when we are not sure whether the muscles are involved or not, when it is doubtful.
Okay. Before we answer that question, tell me
Yes, sir.
what information would MRI give which CT cannot give?
Sir, it will give you details on the soft tissues like muscle involvement, perineural involvement,
Good.
lymphovascular involvement,
What else?
and the spaces, sir. Masticated
Yeah, good.
space.
So basically, MRI of tongue will do in early lesions. Okay.
Yes,
When
sir.
the lesion is very small, okay, but it's very deep. When you
Yes, sir.
palpate, you see the induration, the depth of lesion you're not able to assess. So that's
Yes,
when
sir.
MRI comes into play. You can know the exact the depth of the lesion. Okay. And nowadays we incorporated one more thing in the staging, which is known as depth of invasion. Are
Depth
you
of
aware of
invasion.
that?
Yes, sir.
Is it
Uh,
same as tumor thickness?
no, sir. Actually, it is a pathological uh, staging. Like after in the
Yeah.
pathology
The
assessment
pathological
from
depth of invasion, but
yes,
clinically you can approximately give a depth of invasion
depth
by
of invasion.
pinch test. Okay, although it's not
Okay.
accurate and it's only for
Okay.
early lesions, pinchable lesions. So
Okay, sir.
MRI will give you most importantly the depth of invasion, which will be useful for staging properly. It can tell you whether the lesion has crossed the midline or not, because superficially the growth may be away from midline. But when you
Yes,
see
sir.
an MRI, deeper aspect, okay, the lesion may be crossing the midline. Okay. And vertically down again, you can have an assessment of whether it has involved the muscles of the tongue and the floor of mouth and the perineural invasion and the submandibular and the sublingual spaces. So this is all this information you can get from MRI for early lesion of tongue. But
Okay,
when
sir.
the lesion is advanced and it's clinically evident by ankylosing, by difficulty in swallowing, okay, you can easily make out that the extent is obvious. In that case, CCT would be sufficient because you just now want to know whether mandible is involved or not. So that
Okay, sir.
purpose would be solved by CCT. Okay. Is
Okay,
CT
sir.
just mandatory in all cases or you can do away with X-ray?
No, sir. X-ray chest is enough, sir.
Okay. So when do you do CT chest?
When it is doubtful, the patient is symptomatic about lung malignancy.
Yeah. So the chances of lung metastasis in a quite early lesion is less than 5%. Okay. So chest X-ray will suffice. CT chest you'll do when you have the risk of lung mets to be more. So when do you have the risk of lung mets to be more? When the primary lesion is very bulky, like in
Well,
this case. Okay. Bulky
yes, sir.
primary lesion, bulky nodes, contralateral nodes. So the lesion has reached so far. Okay. So there are high chances that patient may have lung mets also. So in this is an ideal case for a CT chest. Okay. Next, you have another slide.
My treatment.
Okay, fine. So we'll carry on from here. So yeah, so you have staged the disease. Let's say
Yes, sir.
mandible is involved. Okay. It's a
Yes,
locally
sir.
advanced PA tongue. Okay.
Yes,
Now,
sir.
do you have any other investigation to find out the real extent, posterior extent,
Laryngoscopy, sir.
or you are happy with the CT?
I can do a laryngoscopy to see the uh, posterior involvement.
Okay, you want to do an endoscopy to see the
Yes, sir.
posterior extent. Is there any other purpose for doing endoscopy? Anything else you want to look?
Actually, I can do a triple endoscopy, sir, because uh, to look for a second primary
Yeah, very
and
good. So there are two intents. One to look for field calcification. Okay, any other
cancellation.
primary? You can look at the
Yes.
esophagus, larynx, pharynx, other than the oral cavity.
Okay,
Another
sir.
is to ascertain the extent of the tumor. Is there any other method to look for the posterior extent, to find out the posterior extent, other than endoscopy?
Mm. Indirect laryngoscopy.
Other than endoscopy, how do you assess the posterior extent of tumor? We can do examination under anesthesia. Okay.
Okay, sir.
Yeah, then you will not have the gag reflex. So you
Yes.
can just put your finger behind and you can have an assessment. Okay. In
Okay,
fact,
sir.
if you're taking this patient for surgery, irrespective of endoscopy, you have to always examine him after GA. Okay, put your finger inside and then you proceed for the definitive plan, whatever you have. So what do you think this patient will end? Mandible is involved. Okay.
Yes, sir.
Posterior 1/3 of tongue is involved,
Okay, sir.
but it is not reaching the say supraglottis or the vallicular area. Okay. Or the base of tongue. It's just a posterior 1/3 of tongue which is involved.
Yes.
Okay, so will it be resectable?
Sir,
Do
actually,
you want to go for surgery?
in this case, I lean more towards radiotherapy, sir.
Why not surgery?
Sir, because it is involving almost the whole of the left side of the oral cavity, sir, for this patient. It is a, I mean, if I try RT prior to surgery, maybe there is a chance of downstaging.
No, you're confusing yourself.
Okay,
You will
sir.
do surgery or no surgery. Okay. So see, this lesion is very advanced. Okay.
Okay.
Or not only the lesion is advanced, see the nodal mets. It has gone to the contralateral side also. So prognosis is very poor. That is one thing. So always after surgery, you should not only look at the R0 resection. You should also look at the quality of life, right?
Yes.
In oral cavity, a lot of things you have to look other than whether the tumor is resectable. So what will happen to, you're going to remove almost whole of tongue, right? So what will happen to
Yes,
his
sir.
speech? What will happen to the swallowing? Okay.
Allowing.
And you're going to put a bulky flap, right? If you're taking the whole tongue out.
Yes, sir.
So it is going to fall back, right? So he might have difficulty in respiration also. So he might need a tracheostomy also.
Yes, sir.
So even after surgery, he would be in Ryle's tube feeding, nasogastric feeding, right?
Yes, sir.
So he may not be able to regain the swallowing function. So his nutrition may be compromised. He's already a nutritionally compromised patient. So all this has to be taken into account. Okay.
Yes, sir.
So you'll have to discuss, you'll have to say that I'll discuss with the patient. But any cancer case, when you're presenting, before jumping to treatment, as you rightly said, you have to say that I would discuss this case in the tumor board. Okay. So tumor board will include a medical oncologist, radiation oncologist, and a surgical oncologist, and they will decide what is best for the patient. Okay. Fine. If it is a smaller tumor, let's say anterior 1/3 of tongue, what would be your plan?
Sir, I'll do a wide local excision.
Just an ipsilateral nodal mets. Okay.
With ipsilateral nodal mets, sir?
Yes.
Okay, sir. I'll go for a wide local excision with ipsilateral type 3 MRND, sir.
Okay, what do you mean by wide local excision?
1 centimeter clearance of the tumor along with
1 centimeter in which direction?
3-dimensional, sir.
What are the 3 dimensions?
Circumferential, depth.
Okay, one is the lateral, right?
Okay, sir.
So tongue, you have the lateral ones. Okay, medial and lateral clearance. And another is the depth.
Okay, sir.
Fine. And in case of buccal mucosa or floor of mouth, we call it something like a mucosal clearance and soft tissue clearance. And if it's involved bone, we would also add the bony clearance. Okay. So one is in the terms of tissue which you're clearing. Okay. Mucosal margins, soft tissue margins, bony margin. Another way you can put it as the depth of the tumor and the lateral margins. Okay. Fine. So neck dissection type 3 MRND you mentioned, right?
Yes, sir.
Fine. If the nodes were not involved, would you go for a neck dissection?
Yes, sir. I'll go for a selective neck dissection, supraomohyoid neck dissection, sir.
Which levels are covered in supraomohyoid?
Sir, Level 1, 2, and 3, sir.
Okay. So nowadays the nomenclature has changed. You can just mention the levels, okay? Level 1 to 3 clearance, level 1 to 4. mRNA is right, you can still use it, but this would
Okay,
be
sir.
more better in getting the point across.
Okay, sir.
Sir, would you like to add anything?
No, thank you. I think it's been very well covered. Most of
Yeah.
it has been covered.
So
Dr.
CA
Sana, do you
tongue.
have any questions? Sir, any doubts?
Yes, sir. Yeah, go ahead.
Sir, can you give us small summary about how to present the management plan? Because I found it difficult to put into in
Yeah,
framing
okay.
the management
So I'll
plan,
just
sir.
give you I just summarize.
Yes,
So
sir.
any oral cavity case, okay, you have to start with the chief complaints. The chief
Okay, sir.
complaints would be like how we had put it in this case. Basically, he would be noticing an ulcer or a growth. You have to mention the site or the exact location, and then some additional symptoms which we would have, like how we have put it in the chief complaint. That is fine. Then you'll have to ask questions in the structured format, okay, for the
Yes, sir.
cause, for the risk factors, for the complications, and then for any metastatic symptoms.
Yes.
And when you examine the patient, again, start from the oral mouth opening, poor oral hygiene, the dentition, any pre-malignant lesions, movement of the tongue, and then you can come to the tumor. Okay. And then you
Yes,
have
sir.
to explain the extent of tumor as you very well explained.
Yes,
Posterior,
sir.
anterior extent, lateral extent, and also the depth. You'll have to give an idea of the depth also.
Yes, sir.
Okay. And then finally, also you have to go beyond, like I've already earlier I mentioned, no, you don't have to
Yes,
stop there. Tongue, you have to always tell about all the lateral extensions. Okay. We
yes, sir.
always tell the anterior, posterior, midline, and the floor. We stop there. You have to go
Okay, sir.
laterally and go to the mandible, and then the gingivo-buccal sulcus, and then the buccal mucosa, and then the skin. Okay. A
Yes, sir.
very advanced lesion can involve all of that. And posteriorly again, it's the tonsillolingual sulcus and the masticatory muscles.
Yes, sir.
Okay. So it's a very three-dimensional assessment. So you have to always keep in mind oral cavity is not a simple structure. Okay. It's a very
Yes,
complex structure, and it has anterior, posterior, superior, inferior, medial, lateral. Okay. And all
yes,
of
sir.
this have subdivisions also. So you have to be thorough with the anatomy. And one
Yes, sir.
common question they ask is this referred pain and the nerve supply. So you have to be thorough with that. So anatomy is one place you have to be strong as far as oral cavity is concerned. Okay. And palpation, how you palpate, how do you differentiate node from gland, which position you palpate, neck node palpation, all the bony landmarks which we already discussed in the previous case, you should be thorough with that. Okay. And when we come to the diagnosis, yeah, there's not much room for a differential diagnosis here. And management, again, you have to always say that this case will be discussed in the tumor board, and you take it from there. Okay,
Okay, sir.
for diagnosis, you have to have a tissue diagnosis, which is biopsy. You have to have an imaging, which will give you the local extent as well as the stage of the disease. Okay, so for local extent, you have to decide whether it's MRA or CT. For early lesions, it's MRA always. CT is only meant for locally advanced lesions. Okay,
Okay. Okay.
and that CT or MRA would also cover the nodes. Okay, both of
Okay.
them will tell us about the nodal status equally. For the chest, it's always chest X-ray. That is enough. CT chest only when you're suspecting lung mets. So when would you suspect lung mets? As I told you, it's bulky primary or
Well,
bulky nodes, or patients having symptoms of lung metastasis. So once you add up endoscopy to rule out second primary, and if you are doubtful about the posterior extent, say in case of tongue, as in this case. And then when you go for management after the discussion of tumor board, you have to take into account patient factors, tumor factors, and the available treatment modalities. Okay, so it's always a balanced decision. Patient, you have a disease which is resectable, okay, but the patient is not fit. He's having multiple comorbs. His BMI
okay.
is his mutation is very bad. He's having cardiac problems. He's having uncontrolled diabetes. Okay, patient is not, he's having renal failure. The patient won't be fit for any radical treatment. Okay,
Okay.
patient is fit for surgery, but the tumor is very advanced. Again, you cannot give him cure.
Okay, sir.
So the one point which is beyond all this is quality of life. Okay. So that
Okay.
is, you won't be reaching that kind of, this kind of questions in your Viva, but just keep in mind
Okay.
that quality of life, as when you say quality of life, it's going to be, what are the functions?
Sir,
Speech, swallowing,
basically swallowing, respiration.
and respiration. Yeah. So you should keep in mind all these three. So functional status is also important. If you do a major surgery, you put a flap, but the patient is not able to eat. The patient is not able to respire through normal nasal passage. Okay, the
Okay.
patient is not able to speak. Then the surgery is not a success. Okay.
Okay.
So the intent of treatment has to be decided first in the tumor board, whether it's curative or palliative. And if it's a curative intent, it's going to be surgery. And you'll have to add on adjuvant treatment to prevent the recurrence. So that can be a radiotherapy or a chemoradiotherapy. So if it's an advanced disease, stage 1 usually do not require any adjuvant treatment. Stage 2 and 3 requires adjuvant treatment. Okay, in the form of radiotherapy or chemoradiotherapy. Stage 4 is a palliation. Okay, it's usually chemotherapy for palliation. If the patient is not fit for chemotherapy, it's just supportive care by giving painkillers. Okay, and sometimes you can give radiation if it's locally fungating mass to reduce the size of the tumor.
Okay, sir.
Okay, very well summarized. Dr. Sana, I hope your doubts are cleared. Thank you very much, everyone, for joining in. Thank you,
Thank you, sir.
especially Dr. Vijay Sarthi, for conducting
Thank you.
such a
Thank you for
wonderful class
giving
today.
me an opportunity. Thank you.
Welcome, sir. We hope you can join us again.
Sure, sir.
Right.
No issues.
And thank you, Sana, for presenting.
Thank you, sir.
Good night, everyone. We'll call this meeting a close. Thank you, everyone.